Good morning, and welcome to Biospain 2021 10th International Trade Show Partnering. Thank you for coming. Thank you very much for attending this leading international event on biotechnology organized by the Spanish Bioindustry Association, ASEBIO, the Government of Navarre, and the Navarre Public Development Enterprise, SODENA. We are holding this, the 10th edition of Biospain, here in Pamplona, but a lot of people are also following us via live streaming, so welcome to you all. And without any further ado, let's begin. Our first discussion panel is going to set the ball rolling with a big question. Are we ready for the next pandemic? We are going to try to answer this question with the help of Maria Isabel Rodrigo, the Deputy Director for Outpatient Processes and Diagnosis at the Navarre Hospital Complex in Spain, as moderator. And we'll start by envisaging future scenarios with Antonio López Navas, Coordinador of Spain's National Plan Against Antibiotic Resistance of the Spanish Agency for Medicines and Health Products, and Catherine Hawke, Professor in the Faculty of Medicine, the School of Public Health at Imperial College London, UK. We'll then look for biotech solutions for an effective response with Alexander Sandy Douglas, Research Group Leader at the University of Oxford, UK, Juanjo Infante, CEO of Vaccine Spain, and Damaso Molero, CEO of 3P Biopharmaceutical Spain. So, all yours.
Good morning, ladies and gentlemen. It's a great pleasure for me to introduce the round table. Are we ready for the next pandemic? I will add, and for the present ones, from a public health point of view, we could say that there are at least two types of pandemics, the noisy and the silent one. The noisy pandemic is the one that has the greatest immediate impact, where it's urgent to take measures because they affect not only those who suffer from the disease, but also those who do not. These pandemics are usually infectious ones. However, others act in a more silent way, for example, the obesity pandemic. But now we will put aside the second type. A new pandemic carries many unknowns. What will cause it? Where will it start? How will it spread? There are aspects that are simpler to analyze, such as the biology of germs, and others that are more difficult, such as treatment or vaccine development. But there are elements that present real and predictable challenges. For example, how will individuals behave? How will social interactions be like? How big or small will the commitment be of the most favored countries towards the less favored ones? What other myths or misconceptions will spread and what effects they may have? The construction of future pandemic scenarios is a complex and delicate task. Complex in the sense that the different parts are interconnected. For its understanding, it is not necessary to know the dynamics of each part, but also the result of the complete system with all the parts interconnected. In addition to diagnosing, treating, and vaccinating, it is necessary to take into account the social dynamics and psychological aspects that influence the behavior of groups and individuals. Taking the positive side of the current pandemic, we can say it has been a good era for the life science industry and its ability to work with the public sector towards greater partnership. Pharmaceutical companies have formed unprecedented alliances while working alongside governments, international organizations, and philanthropists. Cooperation between levels and between centers has become especially important in order to provide the best care based on the health needs detected. However, the cooperation and collaboration is not only necessary at hospital or city level, but at regional, national, and international level as well. A pandemic is a transnational threat. Countries focusing exclusively on protecting their own population will not end it without a global effort. To prepare, we must start by understanding that the lessons from battling COVID-19 are not just about COVID-19. We will fail if we learn nothing more than how to fight the last war better. We'll have to go a little beyond. Now it's the time to get ready and to realize that the cost of preparedness will be dwarfed by the price of disaster. and to talk about some questions that the title of the roundtable inspired us. Let me introduce our speakers a little bit further. Antonio Lopez Navas is head of the Infectious Diseases Services of the Spanish Agencies for Medicines and Health Products since 2009. He's also the coordinator of the National Plan Against Antibiotic Resistance. He graduated in pharmacy from the University of Alcalá of the Henares. He has a specific training and more than 15 years of experience in the field of anti-infective drug evaluation. He is a member of different working groups, Infectious Diseases Working Party, and the Antimicrobial Expert Group for European Medicines Agency. Professor Katharina Hogg is the Deputy Director of the Abdul Latif Jameel Institute for Disease and Emergency Analytics and Professor in Health Economics at the School of Public Health, Imperial College London. She has specialized in the economics of infectious diseases and the economic evaluation of complex public health interventions. She's the co-convener of the economic analysis of the infected blood inquiry in the United Kingdom, member of the International Young Comparator Unit, advising the UK Cabinet Office on international evidence in the fight against COVID-19, and she was co-chair for economics of the Global Funds Modeling Secretariat for the investment case of the SIX replenishment, and an associate editor of the journal Health Economics. And Sandy Douglas is a pharmaceutical physician. He is a principal investigator at the University of Oxford General Institute. He has been one of the leaders of the university's COVID-19 vaccine program, with responsibility for manufacturing scale-up. Before the university's partnership with AstraZeneca, he had developed the process which has been scaled and established a network of UK and international CDMOs and suppliers which has subsequently formed the basis of AstraZeneca's manufacturing program. Dr. Juanjo Infante joined the private biotechnology sector as a chief scientific officer of ADL BioNature Solutions in 2007, after culminating an academic career in microbiology and biochemistry as senior scientist at the University of Washington in Seattle. In ADL BioNature had led technical and business development of specific drug products, including vaccines for the veterinary industry. Dr. Infante joined Vaxdin in 2013 as chief executive officer, contributing to create a technological platform that allows Vaxdin to develop unique vaccine candidates against resistant bacterial pathogens, which made him an inventor in the major family of patents protecting the technology. And Damaso Molero is a CEO at 3P Biopharmaceuticals, a market-leading CDMO, specialized in process development and GMP, manufacturing of biologics and cell therapy products. Damaso Molero holds a degree in pharmacy from the University of Navarra and executive MBA from ESDEN in Madrid. He has 30 years of professional experience in the field of pharmaceutical development and manufacturing in multinationals such as Glaxo, Roche, Centex, or the Japanese company Shionogi Qualicaps. Some of the most notable achievements that the CDMO 3P Biopharmaceutical has achieved together with its clients include the development of the only recombinant vaccine in the world against leishmania in dogs, and the first biosimilar developed in Spain, both of which are already in the market. And right now, let's start with the questions. I would like to ask to the three speakers, which health threats are the most imminent? Antibiotic resistance, new viruses, tropical diseases? Anyone who wants to start?
I can tell about antibiotic resistance. That is my specialty. Biospain is making vaccines to prevent antibiotic-resistant infections. And one of the things you mentioned at the beginning of your introduction, silent pandemic and noisy pandemic. And it's a nice definition, because I think the pandemic caused by antibiotic-resistant bacteria is at the same time silent and noisy. It's silent because I'm sure that the people in the community, even practitioners, sometimes they are not aware of the magnitude of this pandemic. And noisy because if you look at the figures, they are very dramatic already. 1 million deaths recognized. I'm sure there are many more globally every year. The coronavirus killed 2.5 million in a year, and here it's already killing 1 million. And we expect 10 million deaths by 2050 if we don't change the way we are dealing with this pandemic. This pandemic is already here because the people think that to get a bacteria resistant to antibiotics, you have to go to a hospital, and this is not true. They are with us. We are colonized by bacteria since we are born, maybe even before. And before, all our bacteria were antibiotic sensitive. But now, there in the public, we are being colonized by antibiotic resistant bacteria. We don't know that until we get immunodepressed. A bit, the equilibrium between our immunity and the bacteria is, the bacteria is gaining the fight and then is infecting, and when you try to stop it, you cannot with antibiotics. And this is a big problem. We are healthy, but for instance, I can have Klebsiella with me in my throat. If I eventually develop chronic pulmonary obstructive disease, COPD, I will set up the conditions for that Klebsiella to infect me and produce a pneumonia. And then I will go to the doctor, they will prescribe antibiotics, and maybe they are not going to work. Or they are going to work late until they find the right one, and I'm going to suffer. So this is the big problem. Everybody's going to have problems. Everybody knows about a relative, a friend with problems of infections that cannot be treated easily now with antibiotics. And this is getting very dramatic. These strains of bacteria are being distributed globally, so it is a pandemic. It is a pandemic that is here, and we have to increase awareness to fight it.
Mm-hmm. Antonio, I don't know if you want to add something to... No? Something?
So, in my case, of course, I don't have experience too much about this, and we have here in this, we have excellent experts in this table, but I would like to add only my worry more as a citizen instead of an expert regarding the new or the old diseases, tuberculosis, measles, polio, these kind of things, according or following the tendency that we have now in the society for non-vaccinations. I think it's high risk, maybe it's quite difficult to visualize today, but thinking in the future, if this tendency continue, I guess that the old vaccines that we could consider as a disappear will come again.
Mm-hmm. Mm-hmm. So what are the types of solutions in order to tackle this problem? We are talking about antibiotic resistance. Are vaccines also part of the solution? Anyone who wants to answer the question?
It's not.
Yeah, I think Sandy Douglas is talking, but we are not hearing him.
No.
Let's see. Catherine says, okay, we can hear you, but...
Catherine can hear me.
Okay.
And me too.
Okay.
Okay, now. Sandy, you want to say something, right?
Yeah, I think vaccines absolutely can be and need to be part of the solution to antimicrobial resistance. The previous speaker mentioned tuberculosis. I think that's an excellent example. We've got increasing problems with multi and extremely drug-resistant tuberculosis spreading around the world, spreading from low and middle-income countries into richer countries. It's extremely difficult to treat when it arrives. It takes months or years of treatment, usually intravenous, for the most drug-resistant types. We need new drugs to improve those treatment regimes, but it would be much, much, much better to be able to prevent it. At the moment, the only vaccine we have against tuberculosis is BCG, developed a century and more ago, it's clearly possible to make a vaccine that can have an impact. BCG is partially effective, but we need something that's more effective than that to deal with something that's a threat both to the rich world and to poorer parts of the world.
Okay, yeah, he's pointing out the importance of prevention for infectious diseases is, as we know, for COVID-19 has been one of the key aspects. Okay, so...
so I would like to add that
okay.
The solutions are multifactorial, right?
Right.
We need to invest many more. The problem here is that we need new models of reimbursement of the investment in antimicrobials. We have to increase awareness, antibiotic stewardship. But it's true that prevention, this is what we do in Biospain. We are proposing that, therapeutic solutions, we don't find new families of antibiotics. In the last 4 years,
Right.
only one family was found. And now we have new resistant bacteria to that one. So new therapeutic alternatives like bacteriophages, others, they are going to come. We need them to come, but they are in a very early stage. So prevention is a tool. We know how it works, and we can use it. We are proposing, I'm going to take the same example. If you have COPD in a moderate or advanced stage, you are going to begin to have recurring infections with some bacteria that now they are resistant to antibiotics. Before that happens, we can vaccinate you, and you will have increased immunity against certain parts of the bacteria that the bacteria cannot escape. They cannot escape that immunity. So you are going to contain with your own immunity these infections, and you will not need antibiotics. So this is our proposal. And I'm hoping that it's going to be one of the first tools available to tackle this pandemic.
Great.
So, can you hear me?
Now, yes.
Okay, thank you. I have some problems with the connection. Sorry about that. Thank you. I would like to add something also to that question. I think my colleagues already mentioned that antimicrobial resistance is a very complex problem that requires this multi-sectorial approach. And the One Health approach, you are questioning what type of solutions do we have for tackle this problem. I think the first answer is to have this One Health approach that brings together all sectors and stakeholders, human, animal health, environment, and to communicate and work together. Regarding the specific question about vaccines, probably the current pipeline of new antibiotics that is in development includes around 40 or 50 new antibiotics. These new antibiotics probably address many, but not all, these resistant bacteria. And some of them also will have the potential to treat infection, those infections caused by these escape pathogens, these critical 3 pathogens established by the WHO that are unmet medical areas or needs. However, none of these new antibiotics, or almost none of them, include a novel drug class or mechanism of action. So when an antibiotic is already approved, probably will eventually develop a mechanism for resistance, or a lot of these 40 new antibiotics probably will not or will fail to get this approval. In this scenario, for sure, the new alternatives, including vaccines, antibodies, phages, microbiota, probiotics, are absolutely needed. It's clear that the vaccines have the potential for both treat and prevent infections, and of course should be part of the strategy. Answering the specific question, probably the main strategy remains in the rational use of antibiotics, but this should be combined with these vaccines, new diagnostic tools, and monoclonal antibodies, microbiota to tackle the AMR.
Great. Well, I would like to ask now what policies are being implemented to coordinate a local and global response to new threats. Maybe Catherine, can you tell us something about it?
Yes, thank you. Can you hear me?
Yes.
Great. Yes, so first, good morning to everyone, and thanks for inviting me to this super interesting panel discussion. Can I first maybe comment on the antimicrobial resistance? I think, I mean, if you actually, I think the problem that we are up against is that if you look actually drill down into patient-level records at hospitals, for example, the number of persons at the moment dying of antimicrobial resistance, at least the evidence that we can generate on that, the actual empirical evidence, suggests that these numbers are still quite low. And also evidence from low and middle income countries suggests that at the moment still more people are dying from having no access to antibiotics than than the resistance problem. So I think that problem is, but of course we know that in the years and decades to come, we will be facing an increasing problem due to antimicrobial resistance. So I think I can compare that to our natural environmental resources, to forests, to our clean air and clean water, and which are depleted. So it's a natural depletable resource, an antibiotic. And I think we have to treat it like that. And it requires a concerted governmental efforts to something similar to the Paris Climate Accord in order to deal with that problem. And I agree with the previous speakers when they said that really a One Health approach is needed, and a use of antibiotics in the agricultural area and limitations to using antibiotics in this area have shown great success, for example, in Sweden, which I think introduced some quite stringent legislation on using antibiotics for livestock farming. And so I think it's a multi-pronged approach, which is very difficult to implement for governments who have usually a more short-term approach. Then you asked at the beginning this really difficult question on what would be the biggest threat, a new pandemic or antimicrobial resistance or endemic disease. I mean, the fact is that still, if we take a global approach, more people per year are dying from endemic infectious diseases, the three main ones being HIV, TB, malaria, but also neglected tropical diseases, and we shouldn't forget that. And with respect to pandemic preparedness, I think that the return on investment calculation for pandemic preparedness, which we have done at Imperial, but also others are involved in, I think will be a key priority of research going forward.
Thank you. Thank you. I would like to ask Sandy, can you tell us what made academic, biotech, large pharma partnerships work well in the pandemic?
Sure. So we've obviously had an extraordinary experience at the University of Oxford for academics to end up so rapidly leading a program which progressed to licensure and distribution of now more than 1 billion doses of vaccine. And it's sort of generally known as the Oxford AstraZeneca vaccine, so obviously an academic large pharma partnership, but that misses out the fact that we had a large number, I think about 6 or 7 smaller contract manufacturing and CMC supplier small biotech partners on board and working with the university before we entered a partnership with AstraZeneca. So really the program brought together quite a complicated ecosystem of organizations within the UK and beyond. And I think, you know, trying to draw some broader lessons from that for the future, you know, what was important. Firstly, you know, there was the right capacity in the ecosystem. There had been long-term capacity building, and I'll talk a little bit about that. And then secondly, that capacity was mobilized very rapidly and efficiently when the short-term crisis management need arose. And there were big roles for government in doing that, as well as also trade associations. So on the long-term drug development, what we had, a technology platform, a platform to run large clinical trials within the university. That doesn't happen overnight, obviously, you know that. And it had come from decades of investment, actually in developing capacity for tropical diseases mostly. And I think it's important to understand that that capacity, both in the university and outside, none of it had come from a big, £100 million investment. We're going to create a vaccine development centre. Instead, it had all been competitively allocated funding. And so this had evolved in a very competitive ecosystem, both in academia and also the industrial capacity that we drew on had received little bits of competitive funding along the way. So I think there's a need for caution when governments look at what's happened and think, okay, well, we need to invest a huge amount of money in building a new team, to a new building to make vaccines. That's not quite what happened here. And then when the crisis came along, we had a really very fast response. So first of all, UK Research and Innovation, the main government funding agency, set up a grant call that allocated a number of £1 million in, to several different places, not just us. And it did it very, very quickly. So the call was set up in early February, and the decisions were meant to be 2 weeks. And in actual fact, so I put in an application for manufacturing scale up, and I got a phone call 3 or 4 days later saying, yeah, we can't announce this yet, but you'll be funded. Get on with the work. It was very fast. And we also had a lot of help from the UK Bioindustry Association, the trade association, which was very quick off the mark in helping to coordinate help from the small biotechs. They formed a vaccine manufacturing task force. That then connected to the government's vaccines task force. And it took a few weeks for this all to come together, but by April, we had very good connections into government, and we could get serious support. And by early April, before AstraZeneca came on board, we had about £90 million of government investment in the programme. So this was a really serious public-private partnership. But the sort of major big pharma private part of it only came along after the huge public investment. And that meant that the government was one of 3 parties in the negotiating room when the deal with AstraZeneca was being negotiated. There was the university, there was AstraZeneca, and there was the government. It was the big investor, the big stakeholder in the program. And so it was a very different situation from the usual out-licensing of an early-stage drug candidate to pharma, where pharma has a lot of the power. Pharma's taking a big risk. In this case, the investment to de-risk the product had come from the public sector. The phase 3 trial was already funded. Large-scale manufacturing was already funded. And so government and us, the academics, had quite significant influence in the negotiation. We were able to reject certain partners that didn't share our vision, weren't willing to commit to very large-scale, low-cost manufacturing at cost, at low price, at risk, and instead to partner with AstraZeneca, who have been excellent, but also to negotiate in that deal with AstraZeneca a whole series of provisions to extract maximum benefit both for the UK public and for low-income countries, which was a priority for us as academics interested in global health. So I think, just stepping back and summarising, the government and trade associations, which play a coordinating role, can play a really constructive role in subtly and gradually building long-term capacity in strategically important fields. I think government in the UK did well. It could do better, but I think there is a lot to learn in how governments can respond in crises to connect with innovators. And I think there's some interesting thinking to be done about what the lessons are from our experience about how the maximum public benefit can be gained from future public investment in drug development.
Thank you. So, from your words, I can hear that you were ready, you were fast, and you have good connections. No, I could summarize that. Well, do you feel we could strengthen public-private collaboration in order to spot and contain the next pandemic?
I think, or basically, I have to say that what Sandy is telling us is in line with my thinking, and I quite agree with him. What is evident that the first world, let's say the Occidental countries, Europe, States, Japan, Australia, for example, we never thought that a pandemic could appear as, or we can suffer this kind of pandemic. We thought that it was going to be suffered by other countries. But the reality is that we have had this, we have this pandemic, we have destroyed the economy and the health and the death people that we have had. What the thing is not to say if the public institutions and the private corporations needs to collaborate. Of course, it's evident that the answer is yes. What is really important to understand that the countries have to collaborate. Nobody can be so isolated to manage a pandemic as what we are suffering now. It's really important to collaborate between countries. And something that Sandy said regarding some platforms. So we have to be ready for the future pandemic that nobody knows today. But these kind of platforms that should be developed by each country and as I said, in strong collaborations between different countries in Europe or with the States and others, is not only science and pure technology, it's just to have the industrial platforms ready to be activated as soon as an alert appears. We'll have a kind of alarm. It's really, really important to do that. And of course, to reduce the bureaucracy and to generate talent, because also, at least for the industrial world in which our company is involved, it's evident that the talent is an important value, and we have to generate much more and to generate stable talent ready to be used and to be activated for the next pandemic.
Mm-hmm. Oh, do you want to say something, Alex?
It's important to point out that Sandy also mentioned that they were ready for this after decades of heavy investment. So he's talking about several startups, CMOs, analytical companies making technology platforms, and they don't come in a year, right? So you need to seed, you need to invest heavily to be prepared for this. And here in Spain, for instance, we have some public and private investment, but it's clearly not enough. We need much more to be able to be prepared for bring technologies to work and reach the people in need.
Mm-hmm. Katharina, would you like to add something about it? And then Antonio. Okay.
Yes, thanks. So, yes, indeed. So on the topic of pandemic preparedness, I think this is a really, really difficult area because of the uncertainty of when the next pandemic will strike and with what severity. I mean, we can see that over the past, let's say, 100 years or so, we had roughly every 10 years a pandemic. So when we prepared a report, technical report for the G20 higher level independent panel, we made that assumption. We looked at actually four pathogens that were informed by past pandemics. So we looked at a COVID-like pandemic, a SARS-like pandemic, and sorry, can you hear me? there's some disturbance.
Yeah.
Hello?
Yes, but with
Yes,
some difficulties.
we can hear you, not with a high volume, but we can hear you.
Okay, good. I try to speak louder. So we looked at four potential respiratory pathogens: COVID-like, Spanish flu-like, SARS-like, and swine flu-like. And then we tried to investigate what the return on investment would be in terms of averted years of life lost per dollar spent on pandemic preparedness, and what would be the gain in terms of GDP that was gained due to being properly prepared for a pandemic. And we found that for a COVID-like pandemic, the gain per dollar spent on pandemic preparedness would be over 1,000 life years gained, and that it would be highest for COVID-like pandemic, but that these return on investment estimates were lower for a SARS-like pandemic or a Spanish flu-like pandemic, and they were actually negative for a swine flu-like pandemic because of the lower severity of this pandemic. So I think it's very difficult, and there are high variations in estimates of what actually the return on investment is um, for um, for the most for the pathogens that we saw over the past 100 years. For most of those, the return on investment is very, very clear and very strong and very high, but not for all of them. So I think there will be further research needed in what kind of preparedness measures we want to invest in. Also, I mean, investments into immunization, both in terms of the research capacity to develop vaccines fast, and also, I think, importantly, into manufacturing capacity around the world of vaccines. That really only makes sense if we employ other non-pharmaceutical interventions to prevent an unmitigated pandemic. So our research has shown if we have an unmitigated pandemic that rips through the population, then vaccines, even if they develop very fast, will come too late to prevent major loss of life. So we will be, I think, for any pandemic, be looking at a combination of non-pharmaceutical interventions, so the economic lockdowns and social distancing measures we have seen, plus vaccine investments in vaccine development. So it is, I think, a more difficult answer on that one.
Thank you. I think Antonio wanted to add something about this question.
Yes.
Yeah.
It was related to the question about how could strengthen the public and private collaboration. But I'm having some connection problems. I don't know if you can see me and you can hear me, because I don't see and hear anything. Are you there?
Yes.
Okay, thank you. As I say, it's just a comment about the strengthening the public and private collaboration. I think, I work for a regulatory agency, for the Spanish Medicines Agency, and I think we should pay attention on the example about the development of vaccines, how this collaboration between researchers, public sector, and the pharmaceutical industry. I think Alexander commented on that, and now Catherine. It has played a very important role in the development of the vaccine. They were able to boost the development in a record time. So I think we can apply this example for the development of new treatments for antimicrobial resistance. I'm not talking only about new antibiotics. I already mentioned the alternatives. We also have several reports recommending and examples recommending solutions, including both push and pull incentives or mechanisms, already pilot by some countries, for example, UK, and that has demonstrated some effectiveness. So I think we on one hand, we should look at the example of the vaccines, and also look at these pull and push mechanisms already implemented in some countries to try to solve this, to develop new treatments for antimicrobial resistance.
Okay.
Thank you.
I wonder. I'm sorry to interrupt. I'm not sure if you can hear me, but
yes.
I think I'm really glad Antonio mentioned the regulatory function of the public sector, because I feel bad. I should have mentioned it. it was absolutely critical in our effort. For our phase 1 trial, we had an ethical and regulatory approval within 24 hours of submitting the application. And the UK regulators, we have good relationships with them built up over years. They understand our platform, and they have good scientists. They're able to risk assess if we want to do something that is slightly different from usual, but yet ensures patient safety. They're able to understand and confirm they're happy with that and let us do things in innovation. So I think one of the best investments for governments to make in permitting innovative work in their biotech ecosystem is really good regulators.
Okay, thank you. In the case of 3P, on how to fight against the lack of supply during a pandemic, can you tell us a little bit about it in Amazon?
So we are living hard times. I guess that in short future will disappear. But the main difficulty when there are some kind of shortage is that it's quite difficult for CDMOs, as 3P Biopharmaceutical is, to change from one material to another. In biotech, the product is the process is the product, and it's not so easy to change. It always takes time, and it's quite expensive in any case. So the thing is that what we have done is, of course, when the first difficulties appear, is increase our capacity. We immediately accelerate our investment programs, and now we are generating much more capacity for cell culture, purifications, and analytics. So we are accelerating a lot all our investment plan. Other things that we have done, of course, has been to reorganize our activities, to organize the teams, doing focus on the most urgent projects that we have on our hands, and of course, according the materials availability. Okay. And additionally, of course, talking a lot with our suppliers, or the materials that companies like 3P are using are manufacturing mainly for big corporations that also they have their own difficulties for their supply of materials. And but we have done since months ago a daily fine-tune about the factory needs that we have, and also the capacity to supply, not in the same way than time ago, but they are understanding all our needs in the short term, supplying small amounts of materials that allow us to continue with our activities. So I have to say, and I'm really happy that even the difficulties, 3P Biopharmaceuticals has been capable to maintain all our programs. We have supplied all materials that our customers need for the market, in the cases that the molecule is in the market, and also to maintain the clinical trials that are always has been really very important for us, because we know that in some clinical trials are people involved that with a strong vital dependence of that trial, and we have prioritized our projects just to assure that the clinical trials will be maintained as it has been scheduled. So until now, we have been capable to do that. And I know that the big corporations are manufacturing much more than months ago. They are doing an important effort in building new facilities, new capacities. And I guess that, let's say, during the next 6 months, we are going to continue suffering difficulties. But after that, much more capacity will be available, much more materials manufactured in the States, in Europe, in other countries, as Indonesia, for example. So I have to be satisfied now, and quite optimistic in the medium term.
You were talking about manufacturing. Should more manufacturing be taking place in low-income countries? What do you think about it? Do you want to say something about it?
Would comment on that?
I think that...
If you can hear me, I mean, one
yes,
of the very early priorities for my team was to transfer manufacturing to low and middle income countries. We were setting up manufacturing in India and China in March 2020 at the same time as we were setting it up in the UK. Those were the places we went to because they already had very good, very large scale manufacturing capacity. So India makes 80% of Africa's vaccine supply in usual times, for example. Most of it from one company, the Serum Institute. I think there's very difficult questions about whether new capacity should be set up in countries that don't currently have it, and in particular in Africa. I am worried. I've spoken to people from a couple of countries who have been considering setting up capacity. They want to go for the sort of big bang, the politician wants a building tomorrow. And I think there is a risk of there being white elephants that are not sustainable in the longer term. I think it's quite a difficult question how to set up manufacturing capacity to give areas that don't currently have it more autonomy. It clearly is not possible to have world-leading manufacturing in every country in the world. There has to be sharing, and really the big solution is it's simply volume. If there is an excess of manufacturing capacity worldwide, there isn't a problem with sharing it.
Juanjo, you want to say something about it?
Yeah, I wanted to say that so I guess you are thinking in manufacturing in low and middle income countries to try to distribute there, right, the final product. We need to have real motivation. In my experience, for instance, we have funds to make our vaccines from an international accelerator with different funders, Bill and Melinda Gates Foundation, Wellcome Trust, some governments. I'm not going to reveal which of them, but this is non-dilutive money. It's money just to cover the R&D costs. And but one of them, so there is no condition. I don't have to pay anything back. But one of them, this was pre-COVID-19, set up. The only one condition is when I finish phase 1, it's still several years before the vaccine is going to be available. I have to decide in what countries I can make a viable business plan. And they have the right that if I'm not including in my plan low and middle income countries, if I don't present a way to target these countries, they will get right of the product to do that. With me or without me. And this is a condition for me to get the money. So this is an example that if you want to set up in all the agreements, the conditions to make a viable access in low and middle income countries, you can do it. You can do it before politicians get into play, right? And Damaso was mentioning that we have to collaborate. I think we need supranational authorities to force people in having viable models of targeting the low and middle income countries, and maybe manufacturing there is part of the solution too. But you have to think in advance, and you have to create, as Sandy mentioned, you cannot make that in one day. So you have to, all this investment that we need to have technologies ready for the next pandemic or the pandemic we already have here, have to consider viable models of implementing the solutions in low and middle income countries.
Thanks. Well, I don't know if someone in the audience wants to ask a question. Anyone wants to ask? I see a hand right over there. Yeah, I see too. Can we get a microphone so they can ask the question? Someone? They're going there.
Came to us.
Oh. Let me say, because as people cannot hear you, let me say what you are saying right now. They said that the success of the vaccine is not a scientific success because the scientific part was already done, but it was a government one. That's what is your point right now. And keep going, please.
Yeah, we have to manage the expectations of the society. I mean, they cannot expect that the science can deliver a treatment within months or a year. That's the reason because I want to stress that point. And the second is about global versus local actions. You know, I think that we are still neglecting developing countries here. So we are talking about antimicrobial resistance. As the panelist said, this is not a serious problem in terms of size in the Western and well-developed countries. This is a problem in the linked to poverty. And the prevention is linked to fight poverty. Simple as that. In many of the circumstances, TB is one of the other examples. So unless we consider pandemic and the new global health challenges globally, I'm thinking of the poorly developed countries. I mean, we are not really
Okay.
putting the focus on
Okay.
on the real matter.
Let me tell you what he is talking about. He said that we have to manage the expectation of the population because scientists cannot deliver the solution right away. He's talking also about global versus local. He's talking about that has been neglected the non-developed countries, that prevention is a key to fight poverty. Unless we provide global health globally, we are not going to be able to tackle the solution. That's, I think, what is his point of view. Well, if we don't have a microphone, we have some difficulties with this. Maybe we can have another question, because I saw there was another hand raised. I don't know. It has to be short. Maybe you can come. You can get closer to us so we can hear you, or the microphone is over there already? Okay, great. So we'll have the microphone.
Okay. No, I just had a question because you've talked about manufacturing in low to middle income countries, but I think it's really not a question of if it's possible, it's a question of if there's appetite to do it. And I think I'd be interested to hear your comments on the fact that, I mean, we're throwing away vaccines in the US, in Spain, and we're doing a really poor job of distributing the vaccines around the world. I'm not sure that building plants in different places solves this issue of appetite on government and private enterprise part to actually address low-income countries.
But it's a comment about, you have seen, that it's a problem of distribution, of manufacturing, right? Because we have plenty of vaccines, if I think that's what you were considering, and it's a problem of distribution, right? Okay.
Could I speak to that briefly? Because we've been on the sharp end of this for the last 18 months. It's been a very difficult experience. You know, the position we're in now, vaccines are tools of state power. The distribution of vaccines is now, it's not in the hands of pharma, really. It's in the hands of the governments of the countries where they're made, once the decision is taken on where they are going to be made. So I think there is a role for distribution across multiple countries in diluting the power of individual governments. You know, we now have manufacturing in, I think, more than 12 countries. That hasn't solved the problem, though, because the majority of our manufacturing is still in India. So the Indian government has enormous power over where our product goes. But I think the point about appetite is hugely important. You know, patents are a factor. Tech transfer, however, is much more complicated, but it can be done. We did tech transfer to lots of different places. I've seen Pfizer present. They tech transferred to a new facility that had never made RNA vaccines before in about 2 months. So they can do it as well. They could transfer to India if they wanted to. They just clearly don't want to do it. I think patents and the complexity of tech transfer are a bit of a sideshow. What matters is what pharma wants to do in terms of where it wants to manufacture and what government wants to do in terms of where it distributes the vaccine that is manufactured within its country.
Right.
I would
Yes.
just to add a few comments what you are telling us. It's evident that that collaboration is a must. No, it's not possible to be so isolated and having all capacities and capabilities to develop and to manufacture the vaccines or treatments for in a pandemic scenario. Of course, low-income countries should be, or we would like that they will be involved in the development and manufacturing, but we have to be realistic. So some countries, they don't have enough infrastructure, they don't have talent, and always it takes time. So of course, I'm in favor to facilitate the collaboration, but at the same time, we have to be realistic. Even as I said before, even in Europe or Europe and the States, we have been capable to develop and to manufacture and to generate capacity for COVID in a record time. Because, but also it's important to understand that people or companies and scientists were working on COVID since years ago, a lot of years ago, for different purposes. And also the vaccines that now we have in the market are quite well known for other treatments, not only for COVID. So we have been lucky, but I think that we are not ready for manage the next pandemic that at the moment nobody knows which kind of pandemic could be.
Mm-hmm. Well, thank you. We said we have to finish on time, but we have 5-star speakers, and I wouldn't want to finish the session without every of you tell the audience a takeaway message from this, about this session. Which will be your takeaway message? Juanjo.
I would like to say that people, the society, one important lesson from the COVID pandemic is that we have learned what are the consequences of a global health problem, and the value, now we understand the value of the biotech solutions. And we need everybody to understand the value because we have to reimburse the investment based on the value these solutions are bringing to society. Until we don't recognize that value as a reimbursement for the investment, we are not going to have enough investment to put enough solutions to tackle these threats.
Thanks. Katharina, what will be your takeaway message to share with the audience today?
Well, I think the most important message for us to learn from the COVID-19 pandemic is that, yes, it is very important to have the technological capabilities to deal with the pandemic. And with this, I mean the vaccine development and manufacturing capacities that we talked about, the national laboratory systems, the genomic surveillance, all these things are very important. But what I think what we have learned is that crucial is the governance, is the risk communication from the government that impacts things like vaccine uptake in the population, the adherence to social distancing measures. And lastly, I think what we have learned as well is how important it is for an international cooperation in the response to the pandemic.
Great. Thank you. What about you, Antonio? What will be your takeaway message?
Well, I think that over the past 2 years, we all have learned that our individual behaviors can have an impact on other people's well-being. And this idea is related to this One Health approach, in which all AMR strategies are based. Now we know that to face a pandemic, we have to assume that some behaviors are essential to keep us healthy. And there is some very easy one, for instance, hand hygiene. We all already know that this is a good example on how this very simple good practice can avoid a lot of deaths when being adopted by everyone. So that would be my best message.
Okay, great. What about you, Sandy?
Very simply, I would say that smart public investment in translational research capacity pays off big time. It delivers enormous benefits for society. But also private sector innovation, looking for profit by innovating in a competitive market, that's critical as well. And so what we need to find ways of balancing those things. We can't kill the incentive for private sector innovation, but we do need to think harder about how to deliver maximum public benefit from that public investment. But I think as a start, just more public investment would be good.
Great. And Damaso, what will be yours?
So my bullet points are basically 5. Basically, first, we have learned a lot, and we have used what we have learned. I think as a kind of risk analysis should need to be done globally and to define the strategical platforms that we should have ready to use and to activate as soon as alert appear. Okay. Second, of course, the collaboration. Collaborations between companies, between the academia and the companies, and of course between countries is essential for the management of the pandemic and to react as soon as possible. That has not been happening in this case. Of course, to reduce bureaucracy. The fourth is to generate talent. In Europe, we have an important lack of talent, and that talent should be ready to use. Okay? And as I said before, to generate the critical capacity and to identify the critical materials that we need here in Europe and in the States, let's say, but having it in place, clearly identified, and to be ready to use as soon as another appear again.
Well, thank you. I would like to add that we have to fight the pandemics globally, and we have to fight the noisy ones and the silent ones. We cannot forget the silent ones too. Well, thank you very much. Thank you for the audience. Thank you for the 5-star speakers we have had. It has been a pleasure. We had many other questions we would like to discuss, but we have no more time. So we'll be next time maybe. Thank you. Thanks a lot.
Thank you.
Thank you.
Thank you.
Thank you.